We have a whole bunch, an expanding group of clinical investigators. This is our executive team with the MAP staff, and we also have a series of people I'd really like to thank because they're the next step moving into the future, which is the therapists that we've trained as we're expanding to work on phase 3. This was one of the trainings. Another one, yet another one. We have, we've been doing quite a lot of training. And then we had this investigators meeting at our big psychedelic science conference in April. And so we've now trained over 80 people, 40 male-female co-therapist teams, and they're about to start working in 16 different sites in US, Israel, and Canada to start the process to make MDMA a medicine approved by the FDA. And to give you the good news at the very beginning, just a few weeks ago, the FDA declared MDMA-assisted psychotherapy a breakthrough therapy. And that's the highest program, the most important program that the FDA has to move drugs forward through the drug development system. And they give protocol assistance, they help you figure out commercialization, they have more meetings with you, and so they're actually evaluated by Congress on how well they help breakthrough therapies make it through the system. And I wasn't sure that we would actually get this from FDA. I knew that we deserved it, that it met the criteria for a breakthrough therapy, but that it's such a public demonstration of support. I was a little bit worried the FDA might not want to be so public. And when they did this, it really was the reassurance that they are putting science over politics. And I think that's in fact, in a way, the main message is that in the US and in most regulatory agencies now around the world, when it comes to psychedelics and psychedelic research, the science is really leading the way. We've overcome the backlash and do really have a psychedelic renaissance. There's some other good news as well. It's difficult to evaluate how expensive it will be to go through this phase 3 process. MAPS has raised about $40 million so far over the course of our history since 1986. One of the big variables that's going to impact how much it costs to make MDMA into a medicine is how many subjects we need in the study. And that will depend on the effect size, on the strength of the results. And we're not going to know that for a while. But it's possible we might be able to make it into a medicine, MDMA-assisted psychotherapy for PTSD with just 200 people. This is our America First plan. In a nod to Trump, of course. So if we have a medium to large effect size, we can make it into a medicine for 20 million. If it's a small to medium effect size through the FDA, it'll be 25 million. And if it is this medium to large effect size, we should be able to make it into a medicine through both the FDA and the European Medicines Agency for 25 million. And then if it's a small to medium effect size, we should need about 35 million to make it both approved in FDA and EMA. And then, of course, we're expanding our sites globally. So we're actually working with some people in China right now. We're working with Chinese regulatory agencies and elsewhere. And so of this amount, we have already raised $18 million. So we're in sight of the 25 million, which is our goal right now. And I think we're going to hopefully be able to do it in the next 4 or 5 months, because once people hear that we're this close, and also that we have breakthrough therapy and that it really seems that the science is going to lead the way, I think people are willing to help out and donate the rest of the funds. So that's the good news. And I'm going to talk to you about why we're doing this, and also how we're doing it, and some of the issues that are remaining to be discussed with regulatory agencies. This was some leading neuroscientists at Stanford published an article in Cell about a year ago and said the world's populations need more compassion and empathy for one another. The study of MDMA provides one small but potentially important step towards reaching that goal. So to have neuroscientists talking about empathy and compassion and endorsing the importance of MDMA research, it's a call to action to neuroscience from a very traditional source, the journal Cell. So that was really encouraging, and I think understanding more about mechanisms of action of empathy and compassion is really important. But it's more important, I think, this idea of healing multi-generational trauma. You know, how do we see these conflicts that are passed down, sometimes generation after generation, thousands of years, and how do we impact that? This was Dr. Richard Rockefeller, who was the chairman of the board of advisors of Doctors Without Borders, and he gave a lecture at the Commonwealth Club, and he was our main thought partner and support for Michael and I as we tried to work with the Veterans Administration and Department of Defense. And, I'd like to acknowledge his contributions. He died in a plane crash a few years ago as an accident. But this concept of epigenetics and how we can break cycles of trauma in one generation gives a lot of hope, I think. But I think the deeper reason why we do this is that it's really important, as we've heard from so many of the talks here, that we move past the fundamentalism of different religions, of different countries, different gender, of people thinking that they're somehow disconnected and separate from others and then can shadow aside and demonize them. And so this was Robert Mueller, the Assistant Secretary General of the United Nations, in 1983, wrote this book, A New Genesis, Shaping a Global Spirituality, the fundamental idea being that mysticism is the antidote to fundamentalism. And I think we need to embed tools within our culture in legal contexts for people to have access to psychedelics, not just for healing trauma, not just for us to understand empathy and compassion, but also to really help people have these experiences, not just to know the idea, but experience it directly, this unity and this oneness. And there'll be a load of political implications that flow from that in terms of tolerance, compassion, and understanding. So I think that's the real thing. And we'll eventually have these psychedelic clinics. You'll be able to go to Google Maps and put in psychedelic clinics. And we'll have loads of them in Europe too. This is a chart of the attitudes of American voters over the last 45 years about the legalization of marijuana. And this just shows that the attitudes towards legalization, which is this here, this is against legalization, that this long period of, this is the 60s, the 70s, this was Jimmy Carter again, this is the Reagans, this long period here, and things start moving up again right there. And that's where medical marijuana laws started being passed in America. So the concept is that legalization follows medicalization. So if we can medicalize psychedelics, and our current timetable is 2021, we're working on MDMA, other groups are working on psilocybin, a group called USONA, and Hefter Research. And then I think we have 10, 15 years of psychedelic clinics, and then we're currently projecting 2035 for legalization for all uses, not just through medicine or religion, but for individual freedoms. But, you know, as they say, there's ants in every picnic. So we have had this return of fear and anxiety and return to law and order and drug war escalation. And so is this really going to impact us with President Trump and Attorney General Sessions? And it will impact us in one area, which is marijuana. Right now, since 1968, there's been a federal government monopoly in the United States on federally legal marijuana that can be used in research. And as long as that exists, marijuana can never be made into a medicine in the United States because their marijuana can only be used in research. It cannot be sold as a medicine. Under Obama, in the summer of 2016, the DEA said they would end the monopoly. And around 20 firms have applied since then, but there's been no... And it just came out about a month ago that the DEA, the Drug Enforcement, is willing to grant these licenses, but the Attorney General Sessions is refusing to let them do it. And several days ago, the head of the DEA was frustrated by Attorney General Sessions, who wouldn't let him license any private producers. So I think, MAPS has a small team trying to change this, but I'm not sure how effective we'll be, but we're going to give it a good try. It's been a monopoly since 1968. But with psychedelic research, there's multiple producers. The government doesn't have the same kind of leverage. So there's really nothing that we can do, nothing that we can't do with psychedelics. And this is the reason why I think we're going to make it with psychedelics even under this current administration. This just shows the number. Oops, how do I go backwards? Could we go backwards just one more? Yeah, okay. So what this is a list. This is astonishingly sad. This is the list of soldiers, veterans, who are receiving disability payments in the United States for mental health related disorders. And so right here, there's 868,000 veterans receiving disability for PTSD. This is as of a year ago. There's no more recent figures. And when you add in the other mental depression, anxiety, other disorders, it's almost 1.5 million veterans are disabled to some degree by their experience in war. And this costs our federal government a lot of money. The last time they put out statistics was in 2004. It's the average $20,000 per year per veteran on disability for PTSD. So that's $17 billion a year. And for all of them, it's $29 billion a year. This is enormous cost in money, and beyond that, of course, in emotional suffering. And so there's a great incentive in the military, in Congress, everywhere to provide new treatments for PTSD, because these are all people that were not successfully treated by the currently available medicines or psychotherapies. We're also working with leading Veterans Administration affiliated researchers on non-drug psychotherapies that they've developed, and they're interested in blending MDMA with them. So this is not our method. This is not part of our phase 3 drug development program, but these are studies that we're funding primarily to educate the VA about MDMA. We've been trying that since 1990, and it was through the intervention of Richard Rockefeller and his cousin, Senator Jay Rockefeller, that we were able to build these bridges. And so this was Candace Monson, cognitive behavioral conjoint therapy. It's couples therapy, where one member of the couple has PTSD and it affects the relationship. And this is an ongoing study that Michael and Annie are doing with Candace Monson and Ann Wagner. And it's really getting good results. And we have permission from the FDA, from DEA, from IRB to give both members of the couple MDMA. So we're learning also about couples therapy while we're really primarily treating PTSD. At Yale, we're working with Dr. Ben Kilmendi. This is also part of the VA National Center for PTSD. We've helped train Ben, but he's got his own independent funding, and this is fMRI studies with vets with PTSD given MDMA and taken into a scanner. The study is about to start soon. And Dr. John Crystal is the co-investigator, and he's the head of psychiatry at Yale and is very influential in the VA. And then we're about to start a study with Barbara Rothbaum, who developed prolonged exposure with Edna Foa. She's one of the main experts in research with prolonged exposure, and she's interested in blending it with MDMA because it's very difficult for some people to confront their trauma, and it's re-traumatizing for some people, a lot of dropouts, but it helps some people, but we're thinking when we blend it with MDMA that it could be more helpful. So we'll see that. And I think the main message here is we're reaching out to the thought leaders in PTSD research and educating them about MDMA, and they're seeing the value. So we are making MDMA medicine. We've so far, starting effort in 2000, to do small phase 2 pilot studies where we are looking to refine our method to see which patients we work with best, to look at doses, understand methodology. And so we've so far enrolled 107 people in our phase 2 studies, Israel, Canada, and United States. And so the data that we went to the FDA with to talk about moving to phase 3 was from these 107 people. We tested all these different doses, 25, 30, 40, 75, 100, 125, 150, trying to find both what's an ideal therapeutic dose, but also how do we do double-blind studies. And the idea we had was that low doses would cause a certain amount of confusion with the high doses. That would be the best way to do the double-blind. But I didn't want the low doses to have too much therapeutic potential, because then it would have been harder to find a difference between the groups. So this was the purpose of our experimenting with all these different doses. We also have manualized our psychotherapy. We've developed a standardized psychotherapy based very much on what we've learned from Stan in terms of LSD psychotherapy, but more customized for MDMA and PTSD. And this also has adherence criteria. It's quite educational to read this treatment manual. It's up on the website if anybody wants to read it. And we don't trademark it or anything. This is just the way in which we use to try to teach new therapists about our method and have a standardized method, which still leaves room for individual creativity. This is our summary data. So the primary endpoint, which we're talking about here, this is after only 2 MDMA sessions. Our model includes 3 sessions, about 1 month apart. But we uncovered the blind in phase 2 after the 2 sessions, so people wouldn't have to stay in the placebo group too long. And so what we're showing here is a 26-point difference. The people that got the placebo, which is low dose to 40 milligram, they did get a little bit better. This is around how much people improve from Zoloft and Paxil from the drugs that are available. But when you add the MDMA, it goes way down. And this is the entry point to get into the study, moderate or to severe PTSD. So this is a tremendous, actually highly statistically significant difference. So that's in terms of the CAPS, the Clinician Administered PTSD Scale. But to give you a better sense of it, we have 40 hours of therapy and with 2, a male-female co-therapist team. And the therapy itself was quite effective in the sense in that 23% of the people who were chronic treatment-resistant PTSD at the end of this primary outcome variable measure, 23% no longer had PTSD just from the therapy with the comparator dose, 0 or low dose MDMA, which is pretty good because, again, chronic treatment-resistant PTSD. But when you added MDMA after 2 sessions, it was more than double, 55% no longer had PTSD. And when you look at the 3rd session, now it's 61%. Now, the question is this something that is short-term? The MDMA is so powerful, and then when it wears off, do the problems come back? And so, I guess this, in a way, is the most important slide of all of this, which is at the 1 year or longer follow-up, 2/3 no longer had PTSD. People continue to improve on average. And so this is what's really remarkable, and I'd say this is the data that really persuaded the FDA that there was something remarkable about MDMA-assisted psychotherapy that represented a breakthrough therapy. The lessons that we learned in phase 2 were that the cause of PTSD is irrelevant, that if it's war-related PTSD, complex PTSD, childhood sexual abuse, accidents, workplace accidents, any number of different causes, that the treatment works regardless of the cause of PTSD, which is great because that means we can enroll anybody with PTSD. It's a treatment for the general disease. And a lot of people in the studies with Zoloft and Paxil, they didn't really work that well in men, and they didn't work in combat-related PTSD. They really just worked mostly in women. So we also found that there was really no major gender differences either. We were surprised to discover that the low doses of MDMA enhanced the blinding, but seemed to have an anti-therapeutic effect in that they activated people, got them to sort of engage with their trauma, but their fear wasn't reduced, so they felt more uncomfortable. So it didn't really suggest that this was going to be a way to do a proper double blind. It did improve the blinding, but it made it easier to show a difference between the 2 groups. This was a little frustrating for me because my PhD dissertation at the Kennedy School of Government at Harvard was I thought I solved the double-blind problem. And the beauty of research is you get to check your assumptions. It turns out I was wrong. I started one of the meetings with FDA by saying that one of my favorite quotes is from a former president of Harvard who said, never forget there's always a Harvard man on the wrong side of every issue. And in this case, it was me. And I said, there is no solution to the double-blind problem. We also showed safety, that we could administer MDMA safely to people that were severely traumatized, and we showed a medium to large effect size. And based on this, we did another analysis, and one of the key findings from the early work with LSD and the current work with psilocybin is that there's a direct correlation between the depth of the mystical experience and therapeutic outcome for cancer patients, for alcoholics, for heroin addicts, for people with depression. That's been a common finding both in the early psychedelic research and currently. And so what we were able to do is use the same measure of mystical experience and showed that 0.06 is a full mystical experience on the questionnaire. And so the people that had our placebo or comparator doses really didn't have much in the way of a mystical experience, but active doses were. And there were quite a lot of people who had full mystical experiences, even with MDMA. But what we showed is that there's no correlation with the mystical experience and treatment outcome. It's a different mechanism for PTSD because it's grounded in your biography. It has to do with revisiting the trauma when you're feeling safe and coming to terms with it and expressing the emotions. But this also very much reinforces the way in which our treatment manual is based. It's patient-directed, by the patient's unconscious, and we're not trying to steer them towards a mystical experience. There are other benefits from mystical experiences, but they're not correlated with the reduction in PTSD symptoms. So we took all of this data to the FDA on November 29th, 2016, and had what's called an end of phase 2 meeting. And this is us smiling after the meeting because it went really, really well. We were permitted, then we had the New York Times, we gave them an exclusive, so they were ready to report if it worked. And so this was the very next day. FDA agrees to new trials for ecstasy as relief for PTSD patients, but they have a daily summary, if any of you check it out on the website or on mobile. And so their daily summary the next day was, Trump transitions Standing Rock MDMA. That's where I knew we made it, but we also like to say the first two make you need the third. Standing Rock was an environmental tragedy on the Indian reservation, and there was a lot of protests for that. And then Michael got on Fox News. And for those of you not from America, Fox News is reliably Republican. And this was just a tremendous interview that Michael did, about 6 minutes actually. And so this is part of our effort to really build bipartisan support. And we did that, and then we entered into what's called the Special Protocol Assessment process. And that's an option for pharmaceutical company sponsors. If you want to, once you've been given approval to go to phase 3, you can do this Special Protocol Assessment process where you negotiate every aspect of the protocol with the FDA. And it took us 6 months. A lot of pharmaceutical companies don't do it because it takes so long. But we felt it was essential for such a controversial drug and drug development plan as we have. And so if you come to agreement at the end of this, then basically the FDA says they're guaranteeing that if this design produces evidence of safety and efficacy, they will approve the drug. The only condition is that if new safety concerns arise, they have to take those into account. The biggest issue that we faced with them was this challenge of the double blind. And we basically said there is no solution. If you want us to focus on blinding, we'll use low dose, but it'll make it easier to show a difference between the groups. And we said the real important thing is why bother to use a drug if your therapy will do what you need it to do? And so we felt it's better to compare with inactive placebo. And we've been surprised sometimes, actually, how some people under inactive placebo have had experiences that rarely, but it does happen, both confuse them and confuse the therapists, and the therapists are certain that it was MDMA, as are the patients. And it was really just them wanting to have the MDMA experience that made it look like it. So there is some blinding even with inactive placebo, and this is what the FDA finally agreed. So this is the design for phase 3. Basically what we have is 90-minute preparation sessions, 3, about once a week. Then we have randomized either to the MDMA group or the placebo group. The first session is going to be 80 milligrams. And roughly 2 hours later, we offer people half the initial amount as an option to extend the plateau that they're in this highly functional spot to work on their issues. Then they're going to have the option in discussions with the therapist to keep it the same or to go higher. And then this is also for the third session, that same. And then we have 9 of these, 3 integrative sessions between each one and after the last one. and then the 2-month follow-up. And that's the primary outcome measure. So that's the design of phase 3 that the FDA has accepted through this special protocol assessment. And this is really important because they've really endorsed the idea of the inactive placebo, which was our big issue. And so on July 28th, we received the approval letter. This was very, very important because now we can have confidence that we can go forward. And this is something that they don't revoke, that no matter who's elected president, this stays in existence. And then August 15th, we got the approval for breakthrough therapy. So it's for designations for novel treatments for life-threatening illnesses where the preliminary clinical evidence indicates the treatment may provide meaningful improvement over existing therapies. So this is just a tremendous vote of confidence. And we've had incredible media. It's a big part of our work has been public education. These are sort of oriented from politically left-wing to right-wing. And we've had a lot of military interest. We really have gotten a lot of the veterans on our side. But one of the things I'm most proud of in a kind of peculiar way is this one here, Breitbart.com. That's the website that was used to help elect President Trump. It's very much inflammatory, but they ended up having an article about our breakthrough therapy designation that was totally positive. And a lot of it is because some of the veterans we work with are Republicans, and they have connections. So I think we're doing a very good job of building this bipartisan support. In the 60s, it was psychedelics connected to the anti-war movement, and that's what caused a lot of the cultural divide and contributed to the backlash. And so now, 50 years later, we're sort of aligning ourselves with the veterans community and saying we can help heal the traumas that you've experienced, and let's work together on that. And I think that's part of the reason why I think this renaissance is going to continue to expand and succeed. We're going to start soon with negotiations with the European Medicines Agency. It'll take us probably about a year to figure out what the EMA wants to see in phase 3 studies. It might be the same data as the US, or it might be comparison to standard of care of some sort. So we're not sure how this is going to turn out. But these are our potential locations for phase 3 sites in Europe. And we'll probably start training people for phase 3 sometime about a year from now, maybe near the end of 2018. And we hope to start these studies in 2019 in Europe as well. This is just a simple timeline. We had our end of phase 2 meeting. We worked through the special protocol assessment and breakthrough. What we're starting right now in October is we feel that our training program is not sufficiently robust because the way you train therapists is they work with patients under supervision, and we can't do that with MDMA because it's an illegal drug. We can only do that inside a protocol. So we now have a protocol where every new co-therapy team that hasn't worked on phase 2 will get one PTSD patient to work with in what's called open label. It's all MDMA, no double blind, and it will count for safety from the FDA, but it won't count for efficacy, but it'll be really for training. So this is going to cost us over $1 million to train all of the new teams, but we feel it's like an insurance policy to help them get better results in the phase 3 study. April of 2018 is when we start the phase 3 study. Expanded access, which I'll explain later, will start here. Then the second phase 3 study, spring 2019 and 2021, we think we'll have it approved in both FDA and EMA if the negotiations with the EMA go well. So these are the phase 3 sites in the U.S. I won't read them out, but just you can see that we're trying to demonstrate that people have joked about the Michael and Annie phenomenon. You know, is it people that are just highly skilled, have been focused on non-ordinary states for much of their life and have been highly trained, or is this something that can really be expanded and gone to scale? Can we teach lots and lots of new therapists who don't come from the psychedelic transpersonal community? And so one of the reasons we're doing this in so many sites is to really demonstrate that this is scalable and that these techniques can be taught, and that people need to do their own work. The therapists need to do their own work, and we also have ability to give MDMA to therapists as part of their training. So everyone who hasn't had an MDMA before, if they volunteer for it, they get one session of MDMA in a therapeutic setting, and then one placebo session as well. because we're trying to do pharmaceutical drug development, and because the pharmaceutical companies have so much power, the system is designed to help us succeed. You know, it's the opposite of paranoia, pronoia. The system is designed to help us succeed. And so one of the key things is called the interim analysis. And what that means is when you pick how big you need to make your phase 3 studies, you do a lot of statistical power calculations and you estimate your effect size and you come up with how many numbers of people you need. But you might be wrong. There might be something that's different than your assumptions. And so the FDA not only permits but encourages what's called an interim analysis. So before all your data is in, we're going to do it at 60% of the time. You assess the data. You have a small data monitoring committee that's unblinded, and they're allowed to tell only me whether we need to add additional subjects. And they'll say how many we need, and then if we can afford it, we'll add that, and then we'll get statistically significant results. The issue is, of course, that as you add more and more subjects, you can find statistical differences with smaller and smaller effects. So the question is, even if you get the drug approved, will it be adopted by the therapeutic community and by insurance companies? But the interim analysis helps to pretty much, not quite guarantee, but almost, that we will be able to make this drug into a medicine once we start down this phase 3 route. Expanded access is called compassionate use. And what that means is that if you have a phase 3 study and you have a large waiting list and people can't get into the study, they are allowed to negotiate with the pharmaceutical company and have their own treatments simultaneous with the phase 3 studies. And people can pay for their own therapy. The pharmaceutical company has to sell the drug at the cost, but people can pay for their therapy. So we're anticipating that we're going to get expanded access in the summer of 2019. And what that means essentially is that there can be psychedelic clinics set up in the United States where people can come and pay for their treatment for MDMA for PTSD before the drug is even approved, and just 2 years from now. And again, it's wrapped up in a protocol where, because there's no double blind, we're gathering safety data but not efficacy data. So the therapeutic use of MDMA is actually closer than it seems. Now, how is this going to be regulated? That's a big question. And what the FDA has is what's called risk evaluation and mitigation strategies. And this is the negotiations that we're going to be having about how to control the drug once it's approved as a medicine. So we're going to be proposing that it's only prescribed by certain therapists that we have trained. Normally, if a drug is approved by the FDA, any physician can prescribe it for anything. And that's usually around 1/3 to 1/4 of prescriptions are what's called off-label. So we're going to say, though, that only people that we've trained can prescribe this as a safety thing. It's only going to be administered in certain clinics that have the option for overnight stays, that have bathrooms nearby, the treatment rooms. So it's never going to be a take-home drug. It's always going to be administered under supervision. So as a medicine, that's how we're going to be regulating it. And there's going to be certain defined safety screening. If people have hypertension, they have to have stress tests, various things that it will still only be for limited groups of people, but it's really quite broad who can get it. But I think the parts that we're going to negotiate and not require, we won't require the overnight stays. I don't think we'll require the male-female team. And we won't require adherence to our treatment manual, meaning that once people have been trained in our method, if they want to innovate and they want to use a different method, that would be fine with us. This off-label prescription is really a big issue. And DEA in the past has tried to block off-label prescription for controlled substances, but I don't think they'll be able to do that. And so what we're going to be proposing is that once it's approved for PTSD, that there will be off-label prescription, but that there'll be some sort of patient registry that we'll keep, that if it's prescribed for things other than PTSD, for example, anxiety, depression, social anxiety, eating disorders, substance use, schizophrenia, dissociative identity disorder, any number of things that people might prescribe it for, that the sponsor is notified, that there's a record of it, and we ask the patient and therapist just to sort of qualitatively say, how did it go? And then we'll be monitoring this, and if there's a lot of off-label prescriptions for a certain indication, we'll go ahead and try to do more formalized research in those areas. The other question is going to be insurance. How do we make sure that this is not just available to those people that can afford to pay for it, but it's covered as part of people's insurance? And so this is a negotiation right now. And so we're gathering healthcare utilization data to some extent on the people in our studies. But it's well known that people that have PTSD have a lot of other disorders, problems with anxiety, problems with stress. They use healthcare a lot more. So we think it's clearly something we can demonstrate that it's in the incentive for the insurance companies to cover the treatment. And it's more expensive initially because of all the therapy time, but it's actually less expensive over multiple years when you look at it, that many people who don't get this kind of treatment receive medication for 10, 20, 30 years sometimes. So we think that this is going to be a very important issue. And some people may be surprised by this, but the FDA is actually requiring us to do research in pediatric populations. And I think this is a very good thing, because there are children who have been traumatized, and if you wait till they're later to treat them, it kind of solidifies the problem, and it might be harder to treat, plus they've lost all those years where they're suffering. So we are going to be required to do a study in adolescents ages 12 to 17. Now, we've been able to negotiate this to take place after the drug is approved. So this is what's called phase 4 studies. And we will be trying to gather data. A lot of drugs are used in children that have never been tested in children. And so this isn't just specific to MDMA. The FDA more and more is requiring us and requiring other sponsors to do these pediatric studies. And we've had to negotiate this as part of the special protocol assessment. We think these will start in 2024, but we will be doing these studies in adolescents. And then one of the big issues is going to be, how do we sell this? And we're actually a nonprofit, but we are talking about having a product to market. And that's something that's a taxable situation. And so what we've done is we're trying to show a new model for how drugs should be marketed. In America, a lot of the concern about legalizing marijuana is you have big alcohol, big tobacco, they get into the business, they try to maximize profits, they advertise to children, they do all sorts of things that are focused on making money but not really as responsible as they should be. And so there's a modification of capitalism that's called the benefit corporation, where you maximize social benefits, not profits. So MAPS has created a social benefit, the MAPS Public Benefit Corporation. That's going to be the vehicle that will market MDMA. But there's only one owner, one investor of this company, which is the nonprofit. So the nonprofit MAPS is going to be controlling how this is marketed. And if there is money to be made, then we're going to use that money to fund further research. So there's no private gain. It's kind of a virtuous circle. And that's what we're proposing. And some people are even saying that the entire pharmaceutical industry would be better off if we're in this kind of benefit corporation model. This is framed on my desk, Become More Than a Dream. I actually did MDMA the day before MDMA became illegal in 1985. And I was, part of the day, I was working. And I was writing this letter to Business Week, which was a business magazine. It had an article about PTSD and mentioned MDMA. And so I had a couple paragraphs, and I was writing to this Business Week a letter to the editor, and one of my sentences ended with, I hope that one day the prescription use of MDMA will become more than a dream. And so when I went to print it out, my printer went haywire. And all it printed was this: become more than a dream. I later found that I had mistakenly dropped a hit of blotter acid in the printer. So this is the printer on acid communicating to me. And then this is the dream, that one day I'll be able to have a license to be a psychedelic therapist legally working at a clinic on the beach in Florida. So thank you very much.